everyone. My name is Vasilakis Tsatiris. I'm a current chief resident and incoming cardiology fellow at the University of Pittsburgh Medical Center and a current faculty member of the CardioNerds Academy. Today, we will be discussing new data presented at the American College of Cardiology meeting just this past March involving long-term durability and ATTR therapy. I'm delighted to introduce Dr. Prem Soman, the founder-director of our Amyloidosis Center, who also holds the endowed chair in amyloidosis and heart failure. He's an associate chief of cardiology here and the director of nuclear cardiology here at the University of Pittsburgh. And on a personal note, he's my research mentor. We both just got back from ACC, where he presented a late-breaking clinical trial that is now published in JAMA Cardiology. Dr. Soman, thank you so much for taking time to discuss your work.
Delighted to be here, especially with you, Georgia.
Thank you. So before we dive into these exciting details of this trial, let's take a step back and remind everyone about Acoramidis, a near-complete TTR stabilizer in the treatment of patients with wild-type and hereditary ATTR. Dr. Soman, can you remind us of the key findings of the ATTR CM trial and how it influenced the study aims of this trial?
Sure. Before I do that, Georgia, let's take an even greater step back. And I just want to remind everybody that less than a decade ago, we thought TTR amyloidosis was a rare disease. It needed a biopsy for its diagnosis, and there were no therapies. Fast forward, 7 to 9 years, now we know that it's a prevalent disease. We can diagnose it non-invasively most often, and we have not one, but multiple approved therapies. So that is a remarkable transformation. Now, one class of drugs that is known to be efficacious in the treatment of TTR amyloidosis are the stabilizers. And there are two stabilizers approved. The first one was tafamidis, and Acoramidis is the second stabilizer to be approved. And its efficacy was established in the ATTRibute CM trial. So ATTRibute CM was a randomized trial that allocated Acoramidis or placebo in a 2:1 ratio to patients with symptomatic TTR cardiomyopathy. And at the end of the 30 months randomized phase, it showed a significant reduction in the combined endpoint of all-cause mortality and CV hospitalization. Now, the original analysis was done using a Finkelstein-Schoenfeld pairwise comparison analysis with a win ratio. That was a 4-component hierarchical analysis using all-cause death, cardiovascular hospitalizations, that is the cumulative frequency of cardiovascular hospitalizations, change in NT-proBNP, and change in 6-minute walk distance. That was the original analysis with a win ratio of 1.8.
Thank you so much for that refresher. Let's now go through the study design of this open label extension, this trial. Can you walk us through how the participants were categorized, specifically the continuous Acoramidis group and the placebo to Acoramidis group and the interventions?
Yeah, so at the end of the 30-month randomized phase, all patients were invited to participate in the open label extension phase. And so patients who were originally on therapy continued on therapy into the open label extension phase. That is the group that's called the continuous Acoramidis group. And patients who were originally on placebo in the randomized phase of the trial now were given Acoramidis. And this is the group that's called placebo to Acoramidis group.
Let's dive into those incredible results now. There's some striking hazard ratios presented for mortality benefit and hospitalizations. Dr. Soman, can you tell us about your primary outcomes in this study?
Yeah, Georgia, it's really important to remember that the direct effect of the drug on outcome, the best way to, or that is most effectively gleaned from the randomized phase. Now, when patients go into the open label extension phase, several things happen. There's no longer a placebo group. And remember that these are patients who were sicker at entry into the OLE because they had now had 30 months of placebo. And the two groups have different durations of therapy. In addition, there is a very strong survivor bias because only patients who survive the original trial can get into the OLE. So the OLE tells us about the effect of starting therapy early and continuous therapy. So the direct effect of the drug is gleaned from the randomized phase, and the OLE gives us the hazard ratio for starting therapy early versus starting therapy late. And so for all-cause mortality, there was a significant reduction in the hazard. The hazard ratio was 0.55. That translates into a very highly significant relative risk reduction of 45%. And for cardiovascular mortality, it was a relative risk reduction of 49%.
That's incredible. And thank you for outlining how we should think about these results in context of the study design.